abdominal portion of the EFAST exam and found that it exam is to detect to the search for hemoperitoneum. Now, the goal of the abdominal windows of the FAST exam is to detect hemoperitoneum. What we want to do is to rapidly assess these people for the presence or absence of hemoperitoneum in order to expedite their care and to minimize their morbidity and mortality. A meta-analysis looked at the sensitivity and specificity of the abdominal portion of the EFAST exam and found that it was 79% sensitive and 99.2% specific. Now, a lot of this is going to be dependent upon who's performing the exam and the extent of their EFAST exam. Now, the reason that it's not 100% sensitive is that the detection of hemoperitoneum is more complicated. There's multiple gutters and recesses within the peritoneal cavity. The site of bleeding plays a major role. These patients could be bleeding from their liver or their spleen or from the mesentery. It's going to depend on the patient's position and potentially whether they've had prior surgeries with resultant adhesions. Now, what will the EFAST exam miss in the abdomen? It's going to miss solid organ injury without hemoperitoneum, and that occurs in a significant number of patients. A study done out of shock trauma found that almost a third of patients with liver and splenic injuries did not have associated hemoperitoneum on the initial CAT scan. It will also miss solid organ injury with hemoperitoneum below the threshold, and most would guesstimate that that's around 250 cc's. It's going to miss hollow viscous injuries, and it's going to miss retroperitoneal injuries. So it's important to remember that this is a triaging tool. It's not a definitive tool to decide what patient can be admitted and what patient can go home. Just like we discussed in the cardiac portion of the FAST exam, fluid is formless and shapeless, and it's going to have to take the shape of the container it's in. This is going to be important when we're looking at the peritoneal cavity to determine if a fluid collection is free or if it's localized. It's important to understand fluid movement within the peritoneal cavity. The two most common sources of hemorrhage are going to be the liver and the spleen. So let's take a look at those two examples. A patient with a splenic source of hemorrhage, the fluid is preferentially going to go into the subphrenic space. Therefore, it's essential that you visualize that subphrenic space when performing the perisplenic window. Overflow fluid is going to go across the lesser sac into Morrison's pouch, which is a common area for free fluid localization. And then it's going to go down the right paracolic gutter into the pelvis and into the cul-de-sac. Most patients have a phrenicocholic ligament, which will prevent cephalad to caudal transmission of fluid. That's why the fluid goes across the lesser sac in this direction. In patients with a hepatic source of hemorrhage, fluid is going to first go to Morrison's pouch. Some may go across the lesser sac into the left upper quadrant, but this tends to be an area under higher pressure, so fluid's going to go to the area of least resistance, which in hepatic source of hemorrhage is going to be the right paracolic gutter. So it's going to move from Morrison's pouch to the right paracolic gutter, and it's going to go down into the pelvis. Patients with a pelvic source of hemorrhage, and a common example of that would be a non-trauma patient with a ruptured ectopic. These patients first fill up the cul-de-sac, since that's the most dependent portion of the peritoneal cavity in the supine patient. Once the cul-de-sac is filled up, fluid is going to go up and down the right, or it's going to go up the right paracolic gutter into Morrison's pouch. That's why in patients with concern for a ruptured ectopic, we will do a Morrison's pouch window. So a big take-home point is look in Morrison's pouch for fluid, and also when you're doing the perisplenic window, look in the subphrenic space. Here we can see the sonographic windows of the FAST exam. The pericardial window we've already discussed, and this is to look for hemopericardium. But here we have the three intra-abdominal windows, the perihepatic, the perisplenic, and the pelvic. And these are all based on how fluid moves within the abdomen. We know that a common place for fluid to localize is within Morrison's pouch. That's why we have the perihepatic window. We know that the spleen is a common source of hemorrhage in the peritoneal cavity, and that fluid will frequently localize in the subphrenic space and or the splenorenal fossa. So that's why we have the perisplenic window. And we have the pelvic window, since the pelvic cul-de-sac is the most dependent portion of the peritoneal cavity in the supine patient. Just to give you an overview, the perihepatic and the perisplenic windows are intercostal windows. The indicator is going to be directed in a cephalad direction, and you're going to get a view in the perihepatic window of the liver and the kidney, and here you have fluid in Morrison's pouch as well as in the gutter. And the perisplenic is going to give you a window with the indicator directed towards the head of the spleen and the kidney and any fluid in the subphrenic or splenorenal spaces. The pelvic window is going to be a sagittal window with the transducer placed on the anterior abdominal wall just above the pubic symphysis. And here we'd be able to obtain in this female patient the presence of free fluid in the anterior and posterior cul-de-sacs. So we've covered where fluid is going to be located within the peritoneal cavity, but what is it going to look like? Just like in the cardiac section, remember, fluid can be either anechoic or it can be echogenic. Here's a sagittal window of the pelvis, so anterior, posterior, head, and foot. You've got anechoic fluid in the urinary bladder, but you have echogenic fluid here in the cul-de-sac. Here you have a perihepatic window, so this is the liver, this is the kidney, this is Morrison's pouch, and you have anechoic fluid within there. So depending on how quickly the blood clots, that's going to determine how quickly the echogenic appearance will be present. So just remember, always look for the anechoic fluid, but always consider the presence of echogenic fluid. You don't want to miss large echogenic fluid collections, so look for both types of fluid. Before concluding, let's review some key points. The EFAST exam is not 100% sensitive for the detection of hemoperitoneum. It will also not detect hollow viscous injury, so this is not meant to be a comprehensive imaging modality to decide who can be discharged home. It's not meant to replace CAT scanning. Hemoperitoneum can be either anechoic or echogenic, and perisplenic fluid is usually going to be in the subphrenic space. This concludes the introductory lecture in the hemoperitoneum section. I'm Dr. Robert Jones from Metro Health Medical Center in Cleveland, Ohio. In this video, we're going to go over how to both perform and interpret the perihepatic window of the EFAST exam. In this video, we will discuss the normal sonographic findings of the perihepatic window. We'll describe the sonographic appearance of hemoperitoneum. We'll describe other post-traumatic findings that you may potentially encounter when performing this window. We'll discuss the pearls and pitfalls of the perihepatic window. By the end of this module, the learner should be able to demonstrate the perihepatic window on a normal subject and interpret key anatomic structures. Let's first begin by going over how to perform the perihepatic window. The perihepatic window is performed using an intercostal window. The transducer is placed between the 8th and 11th ribs with the transducer indicator directed towards the patient's axilla. Here you can see the indicator here and here. The transducer is placed in an oblique plane. You're going to be scanning over the top of the intercostal muscles, and the transducer is placed roughly at about the level of the mid-axillary line. In order to help us understand the formed ultrasound image for the perihepatic window. Let's take a look at the perihepatic anatomy using CAT scan reconstructions in various different planes. If we look at this axial cut into the abdomen, you can see that this is anterior, posterior, patient's right, patient's left. You can see that by placing the transducer more anteriorly on the torso, you're still able to obtain a cut that provides a view of the liver, Morison's pouch, and the kidney. You can see that with the transducer placed more posteriorly, you're still intercostally able to obtain an image of the liver, Morison's pouch, and kidney. So you can see that you've got a lot of latitude in obtaining a perihepatic window. However, if we use this coronal reconstruction here, you can see that each image is only going to give you a 1 millimeter slice into that patient's anatomy. And here you can see there's liver, Morison's pouch, and kidney. Here we have a normal perihepatic window. You can see that the transducer is placed intercostally in an oblique plane with the indicator directed towards the patient's head. Here you have the indicator here, and you can see that the orientation would be that this is cephalad, this is caudal, this is lateral, and then this is medial as you're scanning in this direction. So first you have the subcutaneous tissue here. Next you'll come across the liver. Surrounding the liver is Glissen's capsule. If there's no fluid within the peritoneal space, that's going to be directly against Gerota's fascia. Posterior to that, you're going to have perinephric fat, and this can vary in terms of its prominence from patient to patient. You're next going to have the true renal capsule, and then you're going to have the kidney. So anything posterior to the line representing Glissen's capsule and Gerota's fascia, anything posterior to Gerota's fascia is going to be the retroperitoneal space. In this cephalad direction here, you can see the diaphragm, although not visualized on this image. If the transducer had been moved up more in a cephalad direction, we would have included more of the thoracic cavity and would have been able to visualize a hemothorax. By placing the transducer in a coronal plane, you're going to have the ability then to slide in both the cephalad direction to better visualize the thoracic cavity. Here you can see on this image that you've got liver, kidney, you've got diaphragm here, everything to the left of the screen here, which represents the cephalad direction, will represent the thoracic cavity. So this is where you would pick up a hemothorax. Here's where you would pick up any fluid in the subdiaphragmatic space, although remember, in the right upper quadrant, it's less likely to find fluid in this space. Most of the fluid is going to be between the liver and the kidney in Morison's pouch. If we move the transducer, however, in a caudal direction going towards the feet, what you'll end up seeing is the right anterior subphrenic space of the liver. This is an important spot to identify since fluid is frequently found here as it begins to trickle into Morison's pouch. So a patient who has a hepatic injury, the fluid may first start trickling in this direction down into Morison's pouch. A study that looked at this specific coronal window found that the sensitivity for the detection of hemoperitoneum was increased slightly by performing this window.
The gentleman who just came in with the sickle cell, this is who just seen
Remember, out of all the intra-abdominal windows you're going to perform as part of the FAST exam, the perihepatic window is the one where you're going to be most likely to detect hemoperitoneum, regardless of the source of hemorrhage within the abdomen. So it's important that you take a good look at this space for any small collections of fluid. If you don't pick up any fluid in the traditional intercostal oblique window, or when you slide the transducer down to the right anterior subphrenic space using that coronal window. Another option is that you can turn the transducer 90 degrees to obtain a transverse view. So here we have a transverse view now where we're able to see in a perpendicular plane Morison's pouch. This will allow us to detect any fluid collections that we may have missed on our 1 or 2 intercostal cuts. You're potentially able to pick up small medial collections within Morison's pouch. So remember, if it's important for you to detect even small amounts of hemoperitoneum, I would advise you to rotate that transducer if you don't detect anything on the intercostal oblique view. Remember, it's important to be in a true perihepatic window, especially as you're starting off on performing the FAST exam. When you get outside of the true perihepatic window, you have more potential to misdiagnose hemoperitoneum. Here's a patient where they were scanning in the right upper quadrant, but were not in a true perihepatic window. Here you can see liver, and here you can see a coronal shot of the inferior vena cava and the aorta. No kidney is visualized. The novice scanner who was performing this window took a look at the hepatic vein here, saw the curvilinear appearance of it and the anechoic nature, and quickly wanted to make the diagnosis of hemoperitoneum, when in actuality this was the hepatic vein. So in the beginning, make sure that you're in the true window before you make the diagnosis. You may be able to see hemoperitoneum outside of the true window. However, in the beginning, you're going to run the risk of making more mistakes when you're outside of your comfort zone. Here's another example of why it's important to be in the true perihepatic window. As a novice scanner was scanning a trauma patient in the right upper quadrant, they were not in a true perihepatic window. While yes, you do see some liver here, you don't see the kidney here. They were very quick to jump at this black area right here and call it hemoperitoneum. However, as we take a closer look at it, you can see that there's an echogenic wall surrounding the whole area, and this represents the gallbladder, not hemoperitoneum. So again, be careful when you're first starting off and make sure you're in a true window that you're comfortable with in terms of the interpretation. Let's take a look for a second at perinephric fat, since this is something that you're going to commonly see when performing the perihepatic window. Here you've got two different patients. The patient on the left here, you can see on this perihepatic window, the indicator is here. You can see that this is a traditional scanning plane right here with indicator directed towards the patient's head. You have liver, kidney, and in between the liver and kidney there's a echogenic space. This should attract your eye right away since you're looking for something between the liver and kidney, but this does not represent hemoperitoneum, it's perinephric fat. If you take a look at this patient here, you've got liver, kidney, and you've got no perinephric fat between the liver or kidney. So how do you diagnose perinephric fat and not potentially overcall it as hemoperitoneum? When we take a look at this image here real time and we look at the video clip, what you can see is that with respiration you can see sliding of the liver back and forth. So you've got liver here, you've got diaphragm, you've got some of the pleural space being brought in and out of view, and you've got kidney right here. But again, you see this echogenic space. You can see dirty shadowing from bowel on the caudal aspect of it here. But how do you know that that doesn't represent hemoperitoneum or hemoretroperitoneum? What you can see, just like we noticed with the heart, is that the perinephric fat has a fixed geographic appearance because of its structure. So you can see that even though the liver is sliding back and forth, there's a fixed consistency and appearance within that perinephric fat. This is not what you would expect if there was hemoperitoneum or hemoretroperitoneum present. So let's now take a look at the post-traumatic findings that you're going to be able to detect on the perihepatic window. First and foremost is hemoperitoneum. This is the primary goal of the intra-abdominal portion of the FAST exam, and the perihepatic window is a key window for the detection of hemoperitoneum. You'll also potentially be able to pick up both subcapsular hematomas and parenchymal injuries of both the liver and the right kidney, although the sensitivity for the detection of these two entities is not very good with ultrasound. You'll also be able to pick up hemothoraces if you look above the diaphragm, and ultrasound is very sensitive for the detection of fluid within the pleural space. You may also be able to pick up hemoretroperitoneum. However, the sensitivity of ultrasound for the detection of hemoretroperitoneum is poor. Now let's take a look at what hemoperitoneum is going to look like. Hemoperitoneum will be either an anechoic or echogenic fluid collection between Glissen's capsule over the liver and Gerota's fascia in Morison's pouch. Here you can see on this image you've got liver, you've got kidney, you've got this anechoic area that wraps itself around the right anterior subphrenic space, and it's in between the liver and the kidney. Here you can see perinephric fat. So this is the true capsule of the kidney. This is Gerota's fascia. So everything between Gerota's fascia and Glissen's capsule represents hemoperitoneum. Here's a patient that had a grade 4 splenic injury. You can see in the right upper quadrant here that you've got the liver, you've got the kidney, you've got this echogenic area here, which represents perinephric fat. So this is Gerota's fascia here. This is Glissen's capsule. And this large anechoic area represents hemoperitoneum. If you take a look on the video clip, you can see some echoes swirling around in there that represent clotted blood. But you can clearly see that this is a large amount of free fluid within Morison's pouch. This case demonstrates why it's important to sweep through the perihepatic window. If you look at this window on this patient, you can see here's liver, here's kidney, here's perinephric fat, but you don't see any free fluid. So this would be a negative perihepatic window. However, if we begin to sweep through there by angling the transducer in an anterior and posterior direction, we can now see that there's free fluid here, and that's between Glissen's capsule of the liver and Gerota's fascia. This is perinephric fat, this is the kidney, so this represents here hemoperitoneum. And you can see that we started off with a negative window, but by just gently angling the transducer, we were able to pick up subtle collection of free fluid. In this video, you'll see fluid in both Morison's pouch as well as in the right gutter. If you take a look here, you've got the liver, the kidney, and here's a small stripe of free fluid which represents hemoperitoneum. And you can see as the transducer is moved that we're going to get a better visualization now as we move caudally of that gutter. And you can see the tip of the liver here. You can see free fluid here. You can see some bowel intermixed. You can notice the triangular shapes as the free fluid abuts up against the bowel. And you can see the peristalsing of the bowel. Here's a transverse view now. And you can again see liver, kidney, Morison's pouch. There's gallbladder. Let's now take a look at hemoretroperitoneum. It's not a primary goal of the EFAST exam, but not uncommonly will you detect free fluid in the retroperitoneal space. So on this window here, you can see here's liver, here's kidney, here's an anechoic fluid collection here, and here's one here. If we take a look closely and we follow, there's the true capsule of the kidney. This is perinephric fat here. This is Gerota's fascia right here. So this area is all the retroperitoneal space. And you can see that there's some free fluid here intermixed among the fat, and that's the hemoretroperitoneum. But there's also fluid noted between Glissen's capsule and Gerota's fascia. So this patient has both hemoperitoneum and hemoretroperitoneum. Here's a video clip of the same patient, and you'll notice the hemoperitoneum and the hemoretroperitoneum. Again, you look very closely and you can find Glissen's capsule, Gerota's fascia, there's perinephric fat, and there's a true capsule of the kidney. How about a hemothorax? Again, not a specific goal of the EFAST exam, but ultrasound is highly sensitive for diagnosing pleural fluid collections. Ultrasound can pick up as little as 20 cc's of free fluid in the pleural space, while it may take a supine chest x-ray up to 250 cc's before you can detect it. So here, if we take a look, we're a little bit higher up in the perihepatic window. We are seeing liver, but we're not seeing kidney. Kidney's going to be down in here. But what we do see is the diaphragm, and that's our landmark border right here. We do not see any fluid between the diaphragm and the liver. If we did, that would represent subphrenic hemoperitoneum. But what we do see is a large anechoic fluid collection cephalad to the diaphragm, and that represents a hemothorax. You can see lung intermixed within this space right here, as you would expect. And so again, there's lung, hemothorax, there's liver, there's some inferior vena cava being brought in. What about solid organ injury? Again, ultrasound has a very poor sensitivity for the detection of solid organ injury, even in the hands of skilled sonographers. If you take a look at this patient right here, you can see here's diaphragm, here's some of the pleural space, here's liver, here's kidney, here's Morrison's pouch, and there's no free fluid. But what you notice is that the liver does not have a normal homogeneous appearance. If you look, the parenchyma should have a nice homogeneous appearance to it in normal states. However, if you take a look right here, there's a hyperechoic area, and what this represents is a liver hematoma, and we'll show a video clip of it right here. You can see that this part of the liver here has a normal homogeneous appearance, but as you move over to here, you can see this large heterogeneous area that represents a liver hematoma. And most liver hematomas will appear hyperechoic. All right, let's take a look at this case here. You've got liver, you've got kidney. First thing you should notice is that the kidney does not have its normal appearance. But you also see that there's an heterogeneous and echogenic area in between the liver and the kidney. So you see this echogenic line here. This would represent Glissen's capsule. However, if there's no hemoperitoneum, this line would be a combination of Glissen's capsule and Gerota's fascia. So then the question becomes, where is Gerota's fascia, and does this area here represent hemoperitoneum or hemoretroperitoneum. As we take a look at the video clip, you can see there's liver, kidney, there's some anechoic areas here that are right up against this distorted appearing kidney. If we take a look at this video here, which is a little more caudal, you can see that again, the kidney is grossly distorted in its appearance. If we take a look up here at the right anterior subphrenic space, you can see that there's no free fluid up in here. And you would expect that if this area here represented hemoperitoneum, that as it would open up into the right pericolic gutter, that you would see anechoic fluid collections intermixed with the bowel. You don't see that here. So if you go back to this image here, what this represents is liver, kidney. This is a combination of Glissen's capsule and Gerota's fascia. This is all retroperitoneal hemorrhage, and this is a true capsule of the kidney here. This was a patient that had a high-grade renal laceration from a high fall. Okay, now let's go through some images to reinforce what you've already learned during this video. All right, let's take a look at this video. We've got liver, kidney. There's an area in between the liver and kidney, so we need to be suspicious that there may be either hemoperitoneum or hemoretroperitoneum. As we watch the video, you can see here that as we move the transducer, we're no longer in a traditional plane because we don't see the kidney, but we see this anechoic area here. However, if you notice, it's got an echogenic wall surrounding it, and you would expect that if this represented hemoperitoneum, that it would be opening up into the gutter here, which it doesn't. So this is a contained fluid collection. This represents a gallbladder. As we go back to the beginning here, this represents perinephric fat. And you'll see here, this all represents bowel, and you can see it peristalsing. So this patient does not have any hemoperitoneum. This is a normal perihepatic window. How about this patient? As we look first at this perihepatic window, we can see here's liver, here's kidney, and we appreciate this very, very subtle anechoic stripe. So now again, the question becomes, is this hemoperitoneum or is this hemoretroperitoneum? As we take a look here, we see perinephric fat, and we follow that and use that as a geographic border. We can see that comes over the top of this fluid collection. So the fluid collection is sandwiched in between the perinephric fat and the kidney. That would go along with hemoretroperitoneum. As we watch the video clip, you can get a better idea of that as we sweep through the area. That this is sitting right on top of the kidney. It is not opening up into the right pericolic gutter. You can see this following the shape of the container of the kidney. It just follows along. This was a patient that had a very minor renal laceration and had some hemoretroperitoneum, but did not have any hemoperitoneum. This patient here, you can see you've got liver, you follow the border of it, it comes down here. You can see the kidney and can follow the border of it here, and it looks like there's some perinephric fat here. So now you see that there's a very wide area here separating the liver and the kidney. It appears heterogeneous in appearance. It's not anechoic, so this could represent clotted blood. This could potentially also represent fluid within the bowel. So the question becomes, is this free fluid or is it contained fluid within the bowel? As we look at the video clip here, you can see one thing that should stand out to you. If you take a look at this right anterior subphrenic space, the fluid abuts right up against it. If this was fluid contained within the bowel, you would expect that there would be an echogenic wall separating the two areas here. So this is free fluid. You can notice the triangular corners that it's taking within the peritoneal cavity here. And you can see all these echogenic areas. Now this may represent hemoperiton or echogenic clotted fluid. However, if you take a look at this area right here, it has a very suspicious appearance for ring down or comet tails. And when you see that, that should make you think of the presence of free air. And that's indeed what this patient had. This patient had a laceration of the anterior aspect of his stomach. So this was a combination of blood and GI contents, and this represented air. So we were able to know prior to taking this patient to the operating room that he had a visceral injury based on the presence of free air. And you can see that as we watch through the video clip here. It could be potentially easy to want to call this bowel, but again, even though it has a similar appearance to what you would expect bowel contents to have, it does not have an echogenic wall around it, so you have to be careful. This was a patient with a hollow viscous injury as well as hemoperitoneum. How about this patient? Here you've got liver, kidney, you've got Morrison's pouch here, which is empty. You do not see any free fluid within it. However, you do see this anechoic area that stands out to you, so you wonder, could this potentially be free fluid? So let's watch the video clip. What you notice, there are some echoes within there, but this area also has an echogenic wall and border surrounding it. You would expect that if this was a free fluid collection, that it would expand out and fit the shape of the container and open up into the pericolic gutter on the right. You would also expect that if this was a retroperitoneal fluid collection, that there would be some fluid extending around the shape of the kidney here, which you don't see. So this represents fluid within the bowel. This patient has no hemoperitoneum or hemoretroperitoneum. Let's end up with this video. I'll let you watch it for a few seconds here so you can get an idea as to whether or not you think this patient has any free fluid, and then we'll go through it. Okay, let's stop the video for a second, and we'll ask ourselves, do we have any areas that concern us? So we've got liver here, we've got kidney here, we've got diaphragm here, and let's first focus on this area right here. So we do see an anechoic area that should concern us. So since we're in the cephalad portion of the liver, we really want to identify the diaphragm, since that's the boundary between the thoracic cavity and the abdominal cavity. Here we see the diaphragm, here we see the liver. This fluid collection is cephalad to it, so this fluid collection would represent a hemothorax. Is that the only fluid collection that we see that concerns us? No. We can see another fluid collection here in between the liver and the kidney. We've got perinephric fat, and we can see that this fluid collection is between the liver and the perinephric fat. So that would have to go along with hemoperitoneum. But is that all we see? No. There's another fluid collection down here. So here we've got liver, kidney. Here's perinephric fat right here. Here's an anechoic fluid collection, and it's abutting right up against the kidney. So this fluid collection is in between the perinephric fat and the kidney, and that would go along with hemoretroperitoneum. So this patient has all three. He's got a hemothorax, hemoperitoneum, and hemoretroperitoneum. So this concludes the perihepatic mastery series. You're now going to want to go on and practice performing the perihepatic window on normal volunteers. You're also going to want to take the perihepatic quiz to assess your knowledge level.